the race and clinical outcomes sub-analysis was focused on determining whether there were racial or ethnic disparities in that responder trial. Our study objectives were to evaluate the entire cohort by race for clinical pathologic characteristics, analyze the clinical outcomes by race, and determine whether race is predictive of treatment benefit in early hormone-positive breast cancer. The study included about 4,048 women from the responder trial with known race and ethnicity. In regards to clinical characteristics, there were no significant differences in tumor size or lymph node involvement, or even the 21 gene recurrence scores by race. However, there were more high-grade tumors amongst the non-Hispanic Blacks compared to non-Hispanic whites and Asians. In regards to outcomes, the non-Hispanic Black cohort had an inferior invasive disease-free survival of 87.2% compared to 91.5% in the non-Hispanic white cohort. On the other hand, the Asians had a superior invasive disease-free survival compared to the non-Hispanic whites and other racial cohorts. Additionally, the non-Hispanic Black patients had a lower distant relapse-free survival compared to non-Hispanic whites and other races. Adjusting for recurrence score, menopausal status, treatment arm, age, and grade did not seem to alter the impact of race, suggesting that race was independently prognostic in that cohort. In terms of treatment effect, there was no significant interaction between race and treatment arm in either the postmenopausal or premenopausal groups. However, there was a limited number of events in the non-Hispanic Black cohort. Therefore, definitive conclusions about the racial differences in treatment benefit cannot be made. We also looked at treatment compliance by race, and we found that non-Hispanic Blacks were more likely to accept a treatment assignment compared to non-Hispanic whites, and were just as likely to remain on endocrine therapy at that 6 and 12-month mark. This data suggests that the outcome differences are less likely attributable to lack of treatment compliance within that first year. However, data beyond the first year is still immature, therefore longer follow-up is needed to confirm this finding.